Now you have the osseous otic capsule. So osseous otic capsule, this is the bony counterpart. This is the bony labyrinth. Formation of the bony labyrinth is from the cartilage precursors, and it starts from the 14 ossification centers. This is nothing but your mesenchyme. And remember, this bony labyrinth or the otic capsule, it it is one of the hardest bone in the body next to the enamel, and their formation starts by the 15 weeks and they're completed by the 23rd gestational weeks. So that means uh, a fetus can, like a baby can start hearing from the intrauterine, that is from the 25th week properly. Then you have the cochlea, vestibular nerves and the ganglia, and the neural crest origin, say all these vestibular nerves and cochlear nerves, then the spiral ganglia, they are developed from the neural crest, and what they do is they will migrate between this epithelium and the basement membrane of the otic vesicles, and they will integrate with the later on integrate with the hair cells. Now coming to the proper, I think most of these points has been discussed. Only things that has been missed is, the vestibule is, as you know, this is a central chamber, and the size, this is around 4 millimeter in diameter. Now remember all this because I'll be asking questions in the MCQ. Then as we have discussed before, in the vestibule there is an opening for the oval window. The medial wall, as you know, the vestibule contains the utricle and saccule. The medial wall has got a spherical recess for the saccule. Remember SS, it's very easy. So a spherical recess for the saccule and the elliptical recess for the utricle. Yes, the utricle will be lying posteriorly, so this elliptical recess will be lying posteriorly and the spherical recess will be anterior. Now the opening of the vestibular aqueduct lies inferior to the elliptical recess. As I have repeatedly told you, vestibular aqueduct houses your endolymphatic duct. So that opening lies inferior to the elliptical recess. So you have the semicircular canals. The semicircular canals, as I think we have discussed the three numbers, and most of these points has been discussed before, so we are not going to repeat here, except that you have to remember the crest commune length is around 4 millimeter, and the total length of the semicircular canal is around 15 to 20 millimeter long. They have diameter of 0.8 millimeter, and it forms 2/3 of the circle, as I have mentioned before. About the implanted and unimplanted end we have discussed before. So this is important. The utricle and saccule, utricle, and I'm repeating it again, utricle and saccule is being housed at the vestibule, and this utricle and saccule, they sense movement in the horizontal plane and sagittal plane, whereas your semicircular canals will have the sensory perception of angular rotations or angular accelerations and decelerations. So the utricle and saccule will sense the to and fro movement, side to side movement, and the against the gravity there is up and down movements. Now how it is, how we perceive this? We perceive this through the sensory cells. Sensory cells are the hair cells. So the hair cells, we have got, remember this is for the balance. So the hair cells will be there in the utricle and saccule. The hair cells will be there in the semicircular canals. Hair cells will be there in the cochlea also, but they are all different. And for utricle and saccule, remember there is it contains macula. So macula is the area where you have all the sensory hair cells, and the sensory hair cells has got this autoconial membrane. Autoconial membrane is nothing but gelatinous matrix. So this is a gelatinous matrix, and into this the hair cells will project. Onto this, and this is studded with the calcium carbonate. So this is studied with the calcium. So this is floating, over the hair cells, and the specific gravity of this autoconial membranes a little bit higher than that of the endolymph. Since we are talking about the utricle and saccule, this is all part of the membranous labyrinth, and it contains endolymph. So this is floating in the endolymph. Now, the utricle has got this arrangement in the horizontal plane, whereas the saccule has got arrangement in the sagittal plane. So saccule will perceive the up and down movement, whereas the utricle will sense, say side to side and to and fro movements. This will be felt by our horizontal, say, perception, and the saccule will be, any along the sagittal plane. That is your up and down movement. So remember this. This is very important. Now, why I'm mainly concentrating on this otoconia is, see, sometimes what happens is some part of this calcium carbonate breaks down because of degenerative changes or because of trauma. And since their specific gravity, it is more than that of the endolimb, they settle down. And whenever we move, our head rotates, then the endolimb also moves. These sediments will move up. And before, normally what is happening is, whenever we stop moving, this autoconial membrane will stop moving. But the problem here is, whenever there is sediments, the otoliths, we call it otoliths. So whenever there are sediments, they will settle down. And even if we stop moving, this settling down of the, the otoliths will again stimulate the hair cells. Then when it happens, then there's a false information. The eye or the visual input is telling that body had stopped moving. Then your, say, sensory shells from the saccule, utricle, and sometimes it will fall into the posterior semicircular canals. So when it falls in the posterior semicircular canal, that is mostly into the ambulated end, then the perception will be rotational. But if it is in the utricle or saccule, patients will have sense of instability. Now, when it happens, that is known as your benign paroxysmal positional vertigo. So when this otoliths falls into the posterior semicircular canal, as you know, the utricle and the posterior semicircular canal, they are very close. So when it falls in the posterior semicircular canal, mostly it happens when we sleep supine. So that is known as benign paroxysmal positional vertigo. It may be, if it falls in the posterior semicircular canal, it is posterior semicircular canal, benign paroxysmal positional vertigo. If it falls into the, say, lateral semicircular canal, it is lateral, say, lateral semicircular canal, posterior, say, benign paroxysmal positional vertigo. Superior, it is very rare, because superior is, always against the gravity. So the condition is very rare there. So you have to remember, you have to know the idea of this. This is the sensory shells, through which we perceive the movement in the to and fro, then horizontal, side to side movement, and against the gravity. Similarly, you have the semicircular canals. So in the semicircular canals also, they have a sensory hair cells, and here the sensory hair cells are present in the crista ampullaris. This is present in the ampullated end. And also here there is a gelatinous structure, and this gelatinous structure, the hair cells will be here. So they will also have this cupula. This cupula will connect against the opposite wall. So this is another gelatinous diaphragm which connects with the with crista, with the opposite wall, that is your cupula. And below this there is a subcupular space, and the endolimbs, when we rotate our head, endolimbs will pass us through this. And we have the hair cells here. So the hair cells, the longest hair cell is known as the kinocilium. Remaining hair cells are known as the stereocilium. So whenever movement occurs towards the kinocilium, say, suppose this is the longest one is the kinocilium. So whenever movement occurs towards the kinocilium, then there is a stimulation. Whenever movements occur opposite to that, then there is an inhibition. So there is a stimulation and inhibition of the hair cells based on the movement of the the cilia. Similarly, it happens with the utricle and saccule also. So there is a longest hair cells are always arranged in a descending or ascending like this. So whenever the cilia is movement of the cilia occurs towards the, say, longest cilia or hair cell, that is the kinocilium, then there is a stimulation. Whenever the movement is away from your longest hair cells or the kinocilium, the remaining is stereocilia. So whenever it moves away, then there's the inhibition. So you have to remember this. That is how our, whenever we move our head and we perceive the rotational movement. So remember, in case of the utricle and saccule, it is the macula. In case of the say semicircular canals, it is the crista ampullaris. This is the sensory organ. Cupula is present in the crista, in the ampulla of the semicircular canals, and the otoconia is present in the utricle and saccule. So remember this. You have the endolymphatic duct, as we have mentioned before. It has got a communication from the saccule, another one from the utricle. These two join together to form the endolymphatic duct. Then your endolymphatic sac. So endolymphatic sac will be lodged in the posterior cranial fossa between the two dural seats. Okay, and here I want to tell you, when I think this we'll utilize this diagram, this saccule and the cochlear duct. So these two will be joined together by the via the ductus reunions. Okay, remember, you have to remember this. We'll be discussing we'll come to this point. The endolymphatic duct, when suppose there is an increase in the formation of the endolymph, or whenever there is a decrease in the absorption of the endolymph, then a condition known as the Meniere's disease. This is because of distension of the your scala media, and then rupture of the basilar membrane or resonance membrane. Then there will be mixing of the endolymph and the perilymph. Then when this episode occurs, the patient, just before the rupture, patient will have fullness of the ear, tinnitus. Then when the rupture occurs, patient will have hearing loss and vertigo, acute vertigo. So that condition is known as the Meniere's disease. Now coming to the cochlea. Mostly this will be about the bony cochlea. So when we say cochlea, this looks like a snail, and the cochlea has got a 2.5 to 2.75 turns. Now it has got a basal turn, middle turn, and the apical turn. Now it is coil. This is a coil tube around a modulus. Modulus is this. This is the modulus. So along this modulus, you have the inside this tube, again there is a partition via this osseous spiral lamina. This is known as the osseous spiral lamina. So this osseous spiral lamina incompletely divides the the tube of the cochlea. So you can imagine this whole thing is a tube being coiled inside. So it forms, this is the basal turn, this is the middle turn, this is the apical turn. Inside of this, if you have a cross section, then you will have say three parts. Now the osseous spiral lamina will have small perforations through which your cochlear nerve will come. See, from the internal auditory meatus, cochlear nerve will be coming from the internal auditory meatus. Then your cochlear nerve will be passing through the cochlear aperture. So this is known as the cochlear aperture. Now from the cochlear aperture, these nerves will be coming like this, and then you will have the Rosenthal's canal in the osseous spiral lamina. Through this, they will lodge the ganglia, or known as the spiral ganglia. Now spiral ganglia will have the bipolar cells. So from the bipolar cells, the dendrites will be innervating all the hair cells. Then the axons will come as the cochlear nerve to your cochlear nucleus. So this is the modulus, this center, say this is your modulus. From the modulus, you have the different osseous spiral lamina. Now the osseous spiral lamina will be completed by your basilar membrane. See, this is the osseous spiral lamina. This is Rosenthal's canal. You have the basilar membrane here. So basilar membrane. Now this is the basilar membrane. Then you have the stria vascularis on the lateral side. So this is the outer side. This is the stria vascularis. Then you have another membrane known as the resonance membrane. So this will form a triangular, and this is your scala media. Now inside the scala media, you have the organ of Corti. So this is your tectorial membrane. Then you have a outer inner pillar and outer pillar. Then you have inner hair cells and the 3 to 4 rows of outer hair cells. So these hair cells are the sensory organ for the cochlea. Okay, now inside this is tunnel of corti, and it contains cotyledon. The cotyledon is mostly, its characteristic is most like perilymph only, whereas here this contains the endolymph. So this is what is your cochlear duct, what we have been discussing as a cochlear duct. Okay, the stridivascular is the it's highly vascular, and this is the area where your endolymph is formed. Okay, now the tectorial membrane, whenever there is a movement, this is the scala tympani and this is the scala vestibuli. Scala vestibuli will open into your oval window, and scala tympani will open into or will be sealed by your secondary tympanic membrane or round window membrane. So whenever there is a movement, say whenever there is a sound, it travels to the tympanic membrane. Then from tympanic membrane, this is carried to your full plate of stapes. Then there will be vibration of this this area. Then there will be there will be movement of this basilar membrane. This movement is transmitted by this basilar membrane. Then your tectorial membrane, it also moves, and whenever it moves, there is a shearing force created between the inner hair cells and outer hair cells. And when it so happens, then there is a depolarization of these hair cells. And when the depolarization occurs, then this is transmitted as a nerve impulse. So that is how we all are hearing. So that is about the organ of the corti. I think this point has been already discussed. And remember, the osseous spiral lamina, this is the basal turn, for example. The osseous spiral lamina is, and say it's thicker in the basal turn, but it becomes thinner in the apical turn. So similarly, the basilar membrane becomes thinner in the basal turn, and it becomes thicker in the or longer in the apical turn. So because of this mobility, it causes some mobility characteristics, and due to which you can hear frequency sounds in the basal turn and the low frequency sounds in the apical turn. So this representation of the different frequencies of sound in the different parts of the cochlea is known as a tonotopical representations. Tonotopical representations. Okay, so this is if you want to study, I think most of your undergraduate books will not mention much about the tectorial membrane, and the organ of corti is one of the short notes. So if you're interested, then you can read this. So mostly I think the points has been discussed, and the only things that we have left behind is there are some supporting cells which supports the outer hair cells and the inner hair cells. So you have the Dieter cells, then on the outer side you have the Hansen cells. So these cells you have to mention, and then the composition of the tectorial membrane. I have given you this autogallin, collagen type 2, type 5, alpha tectorin. Type 5 I have left out, then beta tectorin, because it becomes very lengthy for you. I think if you mention these points, then you'll score good marks. So organ of corti is one of the short notes, so it's usually is given for the undergraduates, so you have to know about it.